Catherine, I was just wanting to ask you how patients with brain tumour tend to present.
Yeah, so, I think the first thing to say is that about 60% of people diagnosed with a brain tumour will present acutely. They will the two commonest presenting symptoms are, first of all, seizures, and people can go to work completely well in the morning, have a seizure, someone calls an ambulance, taken to A&E, have a brain scan, it all goes from there. Or they present with acute onset new neurology with symptoms initially sort of thought to be a stroke if they have loss of speech or acute onset of weakness, taken to A&E on a stroke pathway, have a brain scan, it's not a stroke, it's a tumour, and it goes from there. Or there are also that group of patients who present really very acutely, where they might see someone like yourself in general practice who are clearly profoundly, with new onset symptoms such as speech or motor disturbance, and they're sent in to A&E or onto the medical take. So that does account for the vast majority of people. But what we really want to but there is also a separate group who present with a less acute, a sort of a subacute change, and that's the group that I think we really want to tease out and talk about today. Most people, the presenting symptoms of a brain tumour depends on the type of tumour and whereabouts it is in the brain. And so the key thing is that people present with progressive symptoms over a period of 2 to 3 months. And those can be disparate symptoms relating to where the tumour is in the brain. So it could be increasing weakness of an arm or leg, but that could be fairly subtle. Tripping over a curb, not picking up your feet properly when climbing the stairs, a progressive tendency to drop things. More commonly with sort of lower limb weakness and sort of a frustration that somebody's stumbling when they're walking, but then that deteriorates or becomes associated with other symptoms. There can be personality change, where someone seems more irascible or disinhibited, speech disturbance, struggling to find their words, but also more subtle things like finding themselves unable to read subtitles or finding that they're getting muddled up when they're trying to compose an email or send a text. And visual symptoms, particularly peripheral loss. And it's not uncommon for us to meet people whose presenting complaint has been minor road traffic accidents. So they're driving and they either don't see a car coming at them from one side, or they're clipping wing mirrors, or similarly, if they're not driving, they're walking into door frames. And so the symptoms can be quite diverse and disparate, but the key thing is that these symptoms increase over a 2 to 3 month period, and different, sometimes very subtle symptoms can come into play. Rajiv's going to talk more about headache, but although people, sometimes do have headache, it's very, very uncommon for headache alone to be the only presenting symptom. And it is much more about being aware of the sort of more disparate, sometimes more subtle symptoms, which are all sort of then becoming more numerous and getting worse over quite a defined period of a number of weeks or a short number of months.
And I think missing brain tumours, it's one of the things we're concerned, one of many things we're concerned about. How important is it in terms of, in terms of prognosis, is it to pick these things up early?
So with brain tumours, so it's really, one of the many important things about brain tumours is that there are more than 130 different types of brain tumour. The gliomas are the commonest primary, so gliomas come in 4 grades. Grade 1 and 2 are low grade, grade 3 and 4 are malignant. Grade 4 is numerically the commonest primary brain tumour, that's a glioblastoma, and that's sort of brain cancer, that's the very aggressive one, and people will have had that for probably only a short period of time. But there are numerous other brain tumours like meningiomas, which may be benign or simply managed with surgery. In terms of prognosis and survival, there is not the same sort of linear relationship as there is with something like bowel cancer, where you pick bowel cancer or cervical cancer up early, and that definitely makes a massive impact on survival. Brain tumours don't have a staging system, so there's a less linear relationship. However, the importance tumour at a time when it gives the patient the best chance to undergo good surgery to resect as much of the tumour as possible, and before matters deteriorate to become very acute with raised intracranial pressure. But it's also important to identify these tumours before people become more disabled and get irreversible deficit. And it's also important psychologically, so that when people begin their journey, that if people feel that the tumour has been slow to pick up, to be identified, people bring a lot of psychological baggage with them in that scenario as well, and the whole journey becomes more difficult. So it is important for those reasons, but it varies as well with different types of tumour as well.
Right, thank you. Reggie, can I just ask you about what sorts, because headaches are what we get particularly concerned about, and I think patients get very concerned as well. What sorts of headaches are you concerned about, and how can we differentiate different sorts of headaches?
Yeah, so the question when faced with a patient presenting with a headache is whether it's a primary headache disorder, which are headache disorders not related to an underlying disease process like a brain tumor or inflammation or meningitis or encephalitis or anything like that, but a condition by itself. And the primary headache disorders most commonly are migraine, less commonly cluster headaches, paroxysmal hemicrania, and various other less common things. But the vast majority of headaches that people present with in primary care, and in fact the bulk of our workload as general neurologists, is actually migraine. And the key thing really is to be able to distinguish between primary headaches, mainly migraine, and secondary headaches, which are caused by underlying diseases like brain tumors. And it's all really in the history. So migraine headaches are typically frontal. So most people who have a headache towards the front of the head eventually turn out to have migraine, unless they have an ENT cause like sinusitis. And they are typically throbbing in nature and associated with nausea or actually vomiting, and photophobia, intolerance of bright lights, have to have the curtains drawn all the time, and photophobia, they are intolerant of loud noises, so people have to turn the TV down and not make any banging noises when mum or dad has a headache. And very typically it's made worse by any sort of movement. So people with migraines very typically like to keep still. So they take to bed, they have the curtains drawn, they have the covers over their head, and they just lie as still as they can until the thing passes. And lying down eases the headache. So that's the kind of history which will reassure you that the headache that the patient is reporting is in fact migraine, and therefore is not going to have an underlying cause. And even if they have a scan and something shows up on the brain MRI scan, it is an incidental finding. It's got nothing to do with that patient's headache, and treating that is not going to make that patient's headache better. So it's really about obtaining that history and being confident in the clinical diagnosis of migraine. So one has to bear in mind that brain tumors are in fact pretty uncommon, and most GP practices will have maybe 1 or 2 patients with it. And if you bear in mind that it is a very small minority of that very rare condition that's going to present with raised intracranial pressure type headaches, then it's highly unlikely. And in fact, my colleague who runs the specialist headache clinic texted me yesterday saying for the first time ever in his 20-year career, he saw a patient referred on the 2-week pathway with raised ICP type headaches, actually had a brain tumor, but they also had really prominent papilledema on examination. So there was a pretty clear clue there. So headaches on their own as a presenting feature of a brain tumor would be incredibly uncommon. And if they do have raised intracranial pressure headaches, then they tend to be worse in the mornings. So lying down actually makes that headache worse, which is the opposite of what happens in migraine. And obviously through the night you're lying down for many hours, and typically that headache will be worse in the morning. And standing up, walking around for a bit makes it a bit better. Then typically Valsalva type maneuvers of bending, stooping, coughing, etc. is said to increase the headache in someone with raised ICP. And it does happen if you really have raised ICP, but it also happens in migraine. So if you ask a patient with bad migraine, what happens when you bend or cough or sneeze, they will say it makes it worse. But that's just part of the whole movement aversion that these people have, and not part of, not indicative of raised ICP. The key thing to look out for is really whether they have progressive neurological symptoms, as Catherine said. And these could be something very obvious like weakness or speech disturbance, but it could be something very subtle like inattention and dyspraxia. So inattention would make you bump into door frames, be less good at driving, scratch the car, one side of the car, clip wing mirrors and unable to reverse paddle and park, etc. And if those things come to light, and particularly if in a few weeks it's progressed, then and typically on examination you may find that there is some lateralized weakness or an upgoing plateau or something like that. But those are the things that would make you think, yes, there is something going on here. So the key thing really is to be able to distinguish between primary headaches, particularly migraine, and a headache plus syndrome, where you have somebody with a new onset of headache which does not have migraine features and is associated with progressive neurological deficits.
So is it useful to check visual fields in those patients? The ones who've got progressive, and we've got somebody who said that they've had a few accidents or they've bumped the car or...
Yes, a basic neurological examination is mandatory in all patients presenting with a headache, and that includes visual field testing by confrontation, as well as examining for papilledema and any limb weakness and reflex asymmetries and things like that. But I have to say, in most cases, if there is a significant lesion causing those symptoms, the history really is enough to have a high degree of suspicion, so you can refer the patient even if you don't have any abnormal findings on that.
And you're saying that the classical sort of raised intracranial pressure, red flag alarm bells that we're sort of taught almost as medical students is not...
It's incredibly rare. It's one of those things that are like classical presentations that we're taught in medical schools of all sorts of things. It's actually pretty uncommon. And in fact, I've never seen one. I asked Adam Zimanski, who is my colleague who runs the regional headache service, and he deals with the primary care headache referral pathways and things like that. Has he ever seen one? He's seen one in 20 years. So it's actually, almost like a case report if it happens. Somebody presenting just with raised intracranial pressure and nothing else.
When you get this,
Catherine.
I was just going to say, when you do get those symptoms of raised intracranial pressure, it's as the crescendo of lots of other things that have built up to that point. For it to jump out, as Rajiv said, for it to just occur on its own out of the blue is just unbelievably rare. And it's when if somebody is presenting with that, then you drill down into the history, and actually there were numerous other things leading up to that point. And so really, as Rajiv has said, for that to be an isolated thing is incredibly uncommon. We need to be asking different questions.
Right, okay. So what sort of other symptoms, I think you've mentioned it a little bit, but Rajiv, what other symptoms would we be looking out for?
So the thing that, as Catherine said, that the symptom that patients with brain tumor present with classically would be a seizure. So a seizure is the one thing that would make me worry that an adult patient presenting with a seizure, you really need to do a scan to exclude an underlying tumor. And we have rapid access for seizure clinic pathways set up in most places in the country. It obviously does not have 100% coverage, but if you have a patient who you think has had a new onset seizure, that would be a very reasonable indication for a 2-week visual referral, say, an adult patient presenting with a seizure.
Are you just talking about or are we talking about different absent seizures or temporal lobe seizures? What sort of things are we talking about?
So you don't necessarily have to have that degree of precision in terms of diagnosing a seizure. Typically, we're talking about an episode of transient loss of consciousness. And the only distinction you need to make is between faint and fit. So if it is not vasovagal syncope, so if you cannot diagnose vasovagal syncope, then that patient needs to be seen in secondary care. If you can diagnose vasovagal syncope, just do a 12-lead ECG, that is normal. patient's fine, they can go carry on with their life. But if you cannot diagnose vasovagal syncope, then the distinction lies between a cardiogenic syncope or a seizure. So depending on your level of suspicion of either of those two things, you refer to cardiology or neurology urgently. And as I said, the first fit pathway is well established here in Manchester as well as in other places, but it might not be the same everywhere. But I think that would be a very reasonable thing to refer on a 2-week wait pathway. The second thing is this more insidious presentation with progressive neurological deficits. And that's a more subtle thing. And then typically, that would be somebody who maybe hasn't consulted their GP very much, and they're brought along by a family member saying, I'm a bit worried about this person. They're a bit more forgetful, they seem to be getting more muddled, they can't get their words out properly, etc., etc. That may present a little bit more acutely and be suspicious of a transient ischemic attack or a stroke, which again obviously has its own urgent referral pathway. So our stroke team does pick up tumors along in the acute stroke presentation, as well as in the TIA clinic when they have their brain scans. They pick up those. So the first seizure type presentations, TIA type presentations, there are well-established pathways for referral, and these patients may well be picked up in those clinics. The headache presentation with a suggestion of progressive, over weeks to months, progressive neurological dysfunction is the one that would need fairly urgent referral. But as I said, it's pretty uncommon for that to happen. In most cases, when you present with a patient presenting with a headache, the key thing is to see if they have migraine. I mean, I always try and diagnose migraine because that's the one thing you can treat. And most people who report progressive headaches to their GP are going through a bad patch of their migraine. When they say progressive, well, they mean it's been getting worse in the last couple of months, but they've always had it. Maybe they had a couple of days of headaches around their periods, or when they're stressed, or when they haven't eaten all day and things like that. But for whatever reason, they're going through a bad patch.
Yeah. And Catherine, I think we talked a little bit, and I think one of our patients in the brain tumour module has got some weird epilepsy type symptoms that you said are quite easy to miss. Can you just talk a little bit more about that?
Sure. So again, it's about being vigilant, and it's about just sort of smelling around, just feeling that something's not right about this person. So if a tumor is particularly in the temporal lobe, so symptoms of seizures depend on, again, the anatomical location in the brain. If it's in the frontal lobe near the motor cortex, that's when people are getting generalized seizures or partial seizures involving their arm or leg. But if it's in the temporal lobe, you can get complex partial seizures, and that can manifest classically as olfactory hallucinations. So people smelling unusual smells or smelling things that other people can't smell, classically burning rubber. And also having the other part of that can be a feeling of sort of impending doom or a feeling of deja vu. And again, if we're aware that those can be really quite concerning signs, it's just something else to be vigilant for and be aware of.
And what about the overlap with dementia? Because some of the things that you're describing, we would notice with patients who've got early onset dementia. How do we start to differentiate that?
So the key thing about dementia is neurodegenerative processes progress at a much slower rate. So it'll be progressing over months to years rather than weeks to months. Anything that is rapidly progressive is what we would be suspicious of for a rapidly growing tumor like a glioblastoma. But in the right sort of age group, if you have a more slowly progressive cognitive disorder, then obviously you think more dementia than brain tumor. Just to add to what Catherine said about the temporal lobe epilepsy, so you have the other three lobes, the frontal lobe, which is mainly motor, so you tend to get limb symptoms, the parietal lobe, which is sensory, so you tend to get funny sensations in the arms and legs, and the occipital lobe, which produces visual phenomena. The temporal lobes is a part of the brain where all of these sensations and motor activity are integrated and attached to emotions and memory. So a key feature of seizures coming from the temporal lobe would be a strong emotional component or a strong memory component. So deja vu or fear or panic sensations, typically sensation in the stomach that rises up associated with abnormal taste and smell, during which the patient goes blank and they can make fiddling movements of the hands. That's thing called automatism. So this used to be referred to as psychomotor seizures back in the day. We then changed the name to complex partial seizures and now called focal unaware seizures, but it means the same thing. It's a focal seizure coming from the temporal lobe.
Can I just mention, Sarah, as well about the age group in which brain tumours are diagnosed? Because again, I think we often think about brain tumours in children and in young adults, and we do see brain tumours in children, but that's really because children are proportionately getting much less cancer of other types. But demographically, malignant brain tumours, glioblastomas, are much more common in the older age groups. They're slightly more common in men and more common in people in their 60s, 70s and 80s. And so they can present with those symptoms which could be written off as dementia or stress or depression or infection or numerous other things. And so for men in their sort of their 60s, 70s, 80s who perhaps aren't very keen to see their doctor with symptoms of that type, and again, this is one of the cases that we've got on the Gateway C, in the Gateway C module, family being concerned about behavioural change and cognitive change. But again, back to the fact that the key thing is progression over a 2 or 3 month period with really hard, obvious change over that time. But just again, being aware that it is that sort of subtle build-up of symptoms coming in that we often don't necessarily think of as being related to a brain tumour, but in fact are much, much more common than the very sort of dramatic morning headaches that everybody tends to think of first.
Yeah. So what sort of investigations are useful for diagnosing brain tumours, Catherine?
Yeah. So the gold standard is an MR brain scan with contrast, and that is the investigation which allows us to both diagnose the tumour but also plan treatment, make judgments about what type it is, what grade it is, and plan treatment. But that's obviously not the first test that everybody tends to get. A CT scan is often the first scan that people get, and that's obviously what general practitioners may be more likely to have access to. But it's really important to just talk a bit more about the use of CT scanning. So a CT scan will show something really gross. So if you have a big malignant brain tumour causing intracranial edema, causing mass effect, it will show on a CT scan. But you can't say anything more than that off the CT scan other than there's a tumour, needs an MR scan with contrast. But importantly, a clear CT scan or a CT scan that does not show an abnormality is not necessarily reassuring, particularly in younger people. So some of the low-grade gliomas are completely invisible on a CT, and just because someone has had a clear CT should not be reassuring if there are other symptoms of concern. It's an MR brain scan, which is the investigation that's needed. I would also say we talked briefly about opticians, and I can see somebody, I'm just sort of scanning through the questions, and without wishing to steal our thunder for later, somebody has asked about doing fundoscopy wearing PPE. Opticians are a super resource, because the opticians, we all know how difficult it is to do visual field tests and fundoscopy and so on in the clinic. And as the years go by, papilledema becomes something that we see less and less, and we may not feel confident about being able to pick it up. But the opticians are a wonderful resource. High street optician, visit to a high street optician, any kind of visual change, because a deficit on the visual fields is really hard neurology. There's pretty much nothing else that causes that type of homonymous hemianopia where somebody has loss of the visual field on one side because a tumour, say in the parietal lobe, is blocking the pathways as they go from the optic nerves round to the back of the brain to the occipital lobes. And so visual field testing and retinal examination done by a regular high street optician is a fantastic resource and a fantastic reassurance if it's normal, and a fantastically sensitive thing to do, because the optician will then either come straight back to the GP or refer them straight to A&E themselves or straight to ophthalmology.
That's really helpful. And then I suppose the other thing that, I know actually in Greater Manchester we can't request CTs and MR brains, or certainly in Manchester I can't, for suspected tumours. What's the concern about incidental findings in these patients? Because it is something that worries me a bit.
A lot. Yeah, the rate of incidental findings on brain scans is really high. I think it might be up to 10%. There are all sorts of little oddities that are seen on brain scans, different types of cysts, vascular abnormalities, lots of things which are completely inconsequential. And it can be very difficult. And so the role of a brain scan to reassure people can actually be counterproductive, and so we ought not to be thinking about doing brain scans to reassure people, because actually it can just open a whole different can of worms. If somebody then becomes aware that they have something inconsequential like a pineal cyst or some sort of little arteriovenous malformation, it is possible for people to become very hooked and very fixated on the idea that all of their symptoms are being caused by that abnormality, and for it to be difficult for them to accept reassurance that that abnormality, first of all, isn't responsible for their symptoms, and second of all, often doesn't need any other action. It doesn't need monitoring, it doesn't need anything else. And so caution, yes, because you unquestionably do get quite a lot of incidental findings on MR brain scans. So again, back to taking a clear history and using the MR scan to confirm suspicions, not to rule out trouble in people with headaches who are otherwise well.
Sure. Can I just add to that the headache that we worry about the most as neurologists in this population of patients, we're talking older patients, is actually giant cell arthritis. And that won't be picked up on an MRI. And that is the one that will make people crazy. And if I get a referral about new onset headaches in a 65-year-old man, I don't really want to know what the scan shows. I want to know what his ESR is and what his CRP is. So that's really the key thing to bear in mind. And if his temporal arteries are tender, the patient needs urgent treatment. And that is far more common than a brain tumor presenting with a headache. So I would worry much more about inflammatory conditions than brain tumors in these patients. There's a couple of questions about cervical spondylosis and migraine in older patients. Shall I go into those now? So the thing about cervical spondylosis.
No, carry on. I was just going to say, particularly, I think that there's a couple that have asked quite clear how concerning new onset of migraine in an older patient is. I suppose we're very clearly taught now that new onset IBS in an older patient is of concern. Is new onset migraine in an older patient a burn?
It would be if it's genuinely a new onset condition. Okay, so we often refer to these patients as new onset headaches, and when you ask them about it, well, they always used to get a couple of days of headaches around their periods, once a month or something like that. Oh yeah, that's when I used to go to bed for a day around my periods. Well, that's actually not new onset. But if it is genuinely new onset, then yes, that patient really does require a scan. So if there is absolutely no history of similar headaches, and that might be headaches that are milder and maybe not associated with quite so many additional symptoms. So they would just have a frontal throbbing headache, which makes them feel a bit sick. And they have to take paracetamol and go to bed for a few hours. That type of headache is often there in the history. But if it is genuinely a new onset headache and somebody who's never had anything like that before, then yes, they do require assessment, A, to confirm the diagnosis, and B, to have imaging. So those patients probably should be referred, but not necessarily on the 2-week wait pathway unless you have other things, such as progressive neurological deficits or papilledema or something like that. Because
questions that came up was something that we talked about, I think, when we did the module, is the fact that migraines can worsen quite considerably, and that they change in severity over people's lifetimes. And I think that's one of the things that worries us. And I think our patient in the module has got worse migraine, so she's convinced it's something else.
Absolutely, yeah. So it still is a migraine. No matter how bad it gets, it's still a migraine. And the scan is not going to add anything to that patient's management. We sometimes end up doing a scan just to mollify the patient, just to reassure them and so on. But as Catherine said, it often ends up creating more problems. You end up with what we call incidental illness, and we call those people vomits, victims of medical imaging technology. And they have a whole lot of anxiety, which then requires more input from psychology and psychiatry and all the rest of it. And as I said, the most worrying headache in adult patients, especially older patients, which is giant cell arteritis, is not excluded by a scan anyway. So a scan is not the answer for a serious headache. It's a proper history followed by appropriate referral and investigations.
Okay. And Catherine, can I ask you whether you've seen any change in your patients that have been coming in through COVID?
We're very lucky as an oncology subspeciality in that we really haven't. Because most people present acutely, because of this business of a seizure or new onset neurology, people have been continuing to attend and brain scans have been continuing to be done because happily it's not an aerosol generating procedure, so they've been continuing. The neurosurgeons have been continuing to operate. So I think the straight answer is no, we really haven't. And we don't think there's been no significant change in our numbers at all. And in terms of the way we manage people, some of the people with lower grade tumors where the surgery is more elective and can be sort of planned over a number of months, they may be, at the beginning, 12 months ago, were perhaps having surgery a little slower than they otherwise would have been, but not in any sort of clinically significant way, but certainly in terms of diagnosis, presentation, treatment for malignant brain tumours, happily our service has been able to continue.
And then there's a really difficult question here, and I'm not sure which of you will want to answer this, is how we distinguish the sort of post-COVID, long COVID brain fog from these symptoms, because they will obviously be a little bit more acute because people haven't had COVID for that long. Don't know whether you want to have a go, Catherine.
Yeah,
first. I think that's our most
same message.
New territory, isn't it, for us?
Yes.
Sorry, Catherine. I was just going to say, we don't really know what long COVID looks like. Is it going to be different to the sort of post-viral fatigue, chronic fatigue, fibromyalgia type presentations that we often see, or is long COVID going to be a different entity? Because people with fibromyalgia often describe a brain fog. It's a fibro fog, and that often starts as a post-viral fatigue syndrome. But the long COVID is going to be different to that. We certainly haven't seen a lot of. There have been rarely some vascular complications with regard to venous sinus thrombosis and strokes and things like that, but pretty uncommon. We haven't seen a big spike in neurological presentations because of COVID. So we don't think COVID primarily causes those things.
I think in terms of the question,
coming back to the thing that you've both said. Yeah, so looking at the more, what you've both said is that about a progressive, and I obviously haven't seen that many patients with long COVID because it is quite new, but actually these things tend to not progress in so much as being more is that going to be something that will help us, do you think?
I think so. So again, I haven't seen a lot of long COVID except in friends and colleagues, and my impression, so I think we come back to, and we make no apology for repeating this message today, this business of progressive symptoms over a 2 or 3 month period. And I think that long COVID, whatever else it may or may not be, I would hope is not progressing over 2 or 3 months as the duration from the COVID infection increases. It seems to be much more of a waxing and waning picture, but it's about different neurological symptoms, lots of different things, writing, emails, vision, unsteadiness, limb weakness, things that could be seizures, mood, all of those things, all sort of building up and progressing. So I would be hopeful that regardless of what long COVID begins to look like, that we're still going to be able to differentiate those people with symptoms worrisome for brain tumours on the basis of the history.
Saying is the key to this is a really thorough history, asking for all of those slightly unusual things that we wouldn't necessarily ask about, increased accidents, these sorts of things, and then just making sure that, I suppose we talk about this with most of our modules and most of our webinars, it's just really clear sort of safety netting of the patients. So sort of saying, I'm not too concerned about this today, but if this or this happens in the next 2, 3, 4 months, I want to see you again and we'll have another think.
Yeah, and I think that no one expects, brain tumours are frightening for GPs and for patients. Nobody, because brain tumours are comparatively uncommon, nobody expects general practitioners to be psychic. But it's about if someone who has, as Rajiv said earlier, if someone who doesn't usually darken your door suddenly comes to you 2 or 3 times over a 6 or 8 week period, and I see that very, very common in people who are ultimately diagnosed, that they've had 2 or 3 or 4 visits to the practice over a sort of 6 or 8 week period with these sort of disparate symptoms. I think that would for me be the red flag, rather than an expectation that anybody's going to be psychic on visit 1 with what are really quite subtle symptoms that would do for lots of diagnoses.
And commonly dragged in by family members, aren't they, Catherine? So it's usually when someone says, well, if a patient comes in and says, I'm really worried about my memory, well, that means there's nothing wrong with their memory. Whereas if someone comes in and says, I'm worried about my husband or wife's memory, that usually indicates a cognitive disorder. So it's that. And then the other route, as Catherine said, is via the optician. So we have a steady stream of patients who have papilledema picked up by the optician, sent into the eye hospital, have a scan which picks up a tumor, and then go to oncology. So, those are the kind of common presentations, apart from a seizure that ends up in A&E and have a scan from there type thing.
And if you've got, a lot of patients with migraine will have visual disturbance.
Yeah.
If they have a hemianopia that, what would you see on visual field examination? Because we both said that actually getting an optician's view of visual fields is quite useful.
Yeah, so typically migraine symptoms are transient. They come on over several minutes and disappear over minutes to hours. So typically the visual disturbance of migraine, which could be in a hemifield, so it could be just on one side of the visual field, typically in the form of zigzags or sometimes actually very rarely colored. Usually a colored thing should make you think not migraine, but usually some kind of passing visual disturbance which spreads across the visual field, taking typically 10 minutes or so to occupy the whole of the visual field, followed by the headache and other migraine symptoms, and then gradually disappears over the next hour. The definition is between 1 and 4 hours. So you would probably not see a patient with a visual field defect because of migraine unless they happen to come into surgery when they're having a migraine attack. And if you do a visual field examination at that point, you will probably find the visual field defect. But the point about structural abnormalities, like a brain tumor, would be that these deficits are fixed and progressive. So there will be a bit of visual field defect at one point, and a few weeks down the line, if the lesion is expanded, then it's going to be a bigger field defect. So by and large, we do see the occasional patient referred in because the visual field defect was picked up by the optician, and the optician suggests referral to neurology, and we see them and they have nothing much wrong, and we conclude that the patient was having a migraine episode when they were at the opticians. So that's a key difference. One is transient, the other is fixed and progressive.
Okay. Another question that we've got on here is how that people with learning difficulties are quite difficult to get the history from, possibly, and whether you've got any thoughts as to how we might diagnose brain tumours or reassure ourselves that people don't have brain tumours in people with learning difficulties.
My guess is you may just need a lower threshold for a scan. What do you think, Rajiv?
Yeah, absolutely. I think if you can't get a clear history, then pretty much all of your diagnostic tools are gone. And then if there is a clear suggestion there might be something wrong with their brain, something new wrong with their brain, obviously they have something wrong with the brain, which is the reason why they have learning disability. But if there is any suggestion things are getting worse, then obviously they need to be referred in. It oftentimes isn't a structural cause. It's usually a passing metabolic disturbance, which in somebody with an intact brain wouldn't cause any problems, but a sodium of 130 or 128 might give somebody with learning disability more confusion, more tremors, more ataxia, etc., which it might not do in somebody with an intact brain. But yeah, if there is
I've got one more question. So one more question, because I think we need to finish. But basically, a couple of people have asked how we can do good neurological examinations quickly.
Get them to walk.
So is there any way you can direct us to, bearing in mind that we have nominally 10 minutes per patient, what can we do? Any resources you can direct us to that will help us do this well and quickly?
Get them to walk, watch them walk.
And we'll walk quickly. Yes, yeah. So go to the door and calling the patient in is a good diagnostic test. If they can walk in unaided without bumping into things or limping or not particularly off balance, etc. Yeah, that's a good thing. But a top-to-toe neurological examination takes just about 2 minutes, maybe 3 to do. There is a set of videos which I'll see. My colleague Matt Jones, who's the medical school lead for neurology, has produced a set of videos which medical students are meant to watch and follow, and he has also published an ebook which has all the neurological science demonstrated on it. So I'll see if I can forward the link to you. So and it's a top-to-toe examination which is pretty quick and comprehensive to do.
But I would also say that the history is, can I just say that I think the history is more specific than the examination. People have asked in the chat quite specific questions about things like loss of upward gaze, which is a very specific symptom. By the time you have neurological weakness, which you can find on an examination, that person's complaining that they're not picking their foot up when they're going over curbs, for example.
That's absolutely right. So in relation to the earlier question about has COVID made any difference? Well, during 2020, all of our consultations were pretty much by telephone. And we don't know the final outcomes yet, but we don't think we've missed many diagnoses by speaking to patients on the phone.
Okay.
So pretty much any diagnosis you're going to make on the history. So by the time I finish taking the history and ask the patient to get on the couch so I could have a look at them, if I don't know what I'm looking for, I'm not going to make a diagnosis. It's happened a very small number of times in 20 years I've been doing this. So the history is absolutely the key, and that'll give you the diagnosis 90% of the time.
Well, I think that's a really useful point. I think we've got a summary slide which just goes on to, have we got the summary slide up, Tashi? Which just basically says what we've been through already, that patients tend to present acutely via A&E with symptoms of a new fit or possible TIA stroke. I think we've been through headache a lot, and headache useful concept that I found really, since we did the module, really useful thing to bear in mind as we go along, is that headache plus is what we're particularly concerned about. So I think that's done, because we've finished just before 2. So I'm really grateful to Catherine and Richard for doing that.
Yeah, thank you very much,
Is there anything
Sarah.
else anybody wanted?
I've just posted a link to an article in the Journal of Neurology, Neurosurgery and Psychiatry, which is a BMJ journal, and it is a brief article titled "The Essential Neurological Examination for Acute Physicians." And from there should be a link to the ebook I was talking about. So if people want to refresh their neurological examination skills, that'd be a good place to look.
That's great.
Okay,
thank you.
and we'll make sure that everybody gets that. Yeah.
Yeah, thank you. And thank you to everyone for their time today. Thank you for everyone for attending. Just a few things I'd like to finish off with before we close the session today. So I did mention earlier, you can now download